morning to everyone. I'm Dr. Carlos Gordillo. I'm from Mendoza, Argentina. I'm working in the cornea department at Zaldivar Institute. And the idea of this presentation is to share with you all the knowledge that we have been learning through the years. So in the past, the only chances we had to propose for the patients with advanced keratoconus was contact lens until they don't tolerate anymore. And after that, the corneal keratoplasty, the penetrating keratoplasty. So this has been changing through the years and the advance of the ophthalmology. So right now, we like to call this treatment of the keratoconus as personalized. It should be personalized because every case has to be studied as an individual case. But we need to know which is the classification to understand which one is the best treatment for each patient. So we have a lot of classifications. Actually, right now they're still changing. But the classic ideas were proposed by Amsler, Krummeck with stages. Then we have some morphological classifications with phenotypes, the ABCD grading, and the Oviedo classification is also morphological. The ideas of all of these classification is to understand the stage of the keratoconus and how advanced it is. We need to just a quick review of each classification. With the Rabinovich classification, the keratoconus is classified according to cone morphology and the topography patterns. In the Amsler classification, they describe the different stages of the keratoconus using the plastic disc and with the biomicroscopic findings. And then the Berlin proposes keratoconus staging, incorporating the anterior and posterior curvature of the cornea, the thickness pachymetry, the corrected visual acuity, and they propose 5 different stages. It's pretty complete. And then we have Fernandez Vega et al. Classification from Oviedo that also proposes a classification using pachymetrical maps, the thickness point of the cornea, and its distance from the center of the pupil to the thickness point, and they classify the keratoconus as central, paracentral, and pericentral. So once we have identified the stage of our patient, we can propose different alternatives to solve the situation. So these alternatives will depend on different on our possibilities to accede to the technique, but of course, as early we treat the patient, best results we're gonna have. As you know, the keratoconus is bilateral, asymmetrical, and progressive. So we always need to take a look to both eyes, and as you can see in these publications, you can use all kind of surgical techniques to halt the progression and to solve the irregularity of the corneal surface. I put this topography map of the world where you can see the different mountains and the highest mountains worldwide. I remember when I was trying to understand, when I was studying the topography, it was very helpful for me to understand which was the hot part of the topography and the highest. As you can see, we have people from worldwide here, so I for sure that you can check how high is your country or your region, and remember that as the cone. Once you identify the cone, you need to understand that the different keratometric values will be according to the evolution. So what to do with the patient? What we can do? First of all, when we suspect the keratoconus, we need to do a corneal follow-up with topography. We need to do surface treatment. It's very important at the beginning because we know that if you don't treat the patient accordingly, you're gonna have evolution and progression of the keratoconus. If you have progression, you need to indicate the cross-linking. We have been performing cross-linking in young people, and our youngest patient is 10-year-old, because the progression was really increasing very bad, and we need to halt the progression to avoid the asymmetry. If you have a progression and asymmetry with keratometrics values under 57, you can do a combined technique with cross-linking to halt the progression and with intracorneal rings to improve the corneal service. And finally, if you have a progression with the keratometric values more than 57 and low visual acuity, you'll have to do a DALK. It's a deep anterior lamellar keratoplasty. Well, the idea of this webinar is to make a quick review of each stage and alternatives. So what I was saying before, the corneal surface is really important. It's been described different inflammatory process because of the eye rubbing. And there are videos that you can see in YouTube also about how the eye rub can affect the cornea and the whole globe. So it's very important to understand that all stages need to do the corneal surface. You can halt the progression in the early beginnings. So you need to do this to all patients. The alternatives, you don't need to do much, but you can just use cyclosporine or artificial tears, and also you can add a ponton plaque to improve the tear film. So here is a topography of a patient before the corneal surface treatment and after. You can see it's been followed up for many years after the treatment, and you can see it's still there, the ectatic area, but it's better. So what to do? I'm gonna show you the different alternatives. Here you can see as the first step, we can use the cross-linking. The second step, as I was telling you before, the intracorneal rings and cross-linking. If the evolutive stage is it's bigger, you can use the graft. But also you need to understand that after the graft, you'll have to perform cross-linking again to the peripheral ring. I'm going to talk about that. And how to solve the residual refractive error. You can use ICL or different IOL. So as I was saying at the beginning, you need to consider that it's a bilateral disease, it's progressive and asymmetrical. Asymmetrical means that it's more in one eye than the other one. Usually it's like that. We need to get used to ask our patients about the family history. We need to consider the age. We need to look for the evidence of progression, the corneal thinning, and the pachymetry, of course. So how we identify the progression, what and when? We have the objective progression that we can see in the topography maps. Then we have the manifest refraction that is changing more than 1 diopter or more than 0.5 diopters of equivalent spheric. And when there's a difference between one eye and another, more than one, when the axis is not coincident in the refraction with the autorefractometer and the manifest refraction, when there is a reduction of the pachymetry, and of course, when the patient tells us that the vision is changing. Sometimes we don't see the progression at the beginning because we don't do topography to all patients, but if they are changing the glasses and they tell us they have changes in the vision, we need to pay attention on that. Then another case of progression. This is I was looking for very big cases with a lot of evidence. So you can see this patient. We saw them in 2005 with this small cone. The pachymetry was low, but we indicated cross-linking on that moment. The patient never did it, and they came back on 2009, 4 years after, with this huge cone, and the progression was like very big, and the necessity of a graft was there. So this is a very like good case to show you how the progression can appear if you don't treat it. So I'm going to tell you a few things about the cross-linking. What is it? It's an association process of one or more molecules through the covalent unions. And some history. This doctor was Theo Thaler. He was a professor at the Dresden Technological University in Germany, and he described the process of cross-linking between 1987 and 1990s. He described the collagen polymerization after he was at the dentist. They were doing like a treatment at the dentist with a photopolymer to fix one teeth, and that's when he started thinking about the idea of performing cross-linking. So they started an investigation that was carried in 1997, and the first publication with the result was made in 2003 with 23 eyes with progressive keratoconus that were treated and with safe and reproducible results. So right now we have a lot of different alternatives of cross-linking. The conventional is the one described by Dresden protocol. The accelerated is the one I'm going to show you today. And then we have some other types, the transepithelial and the iontophoresis cross-linking. But I'm going to tell you more about the accelerated one. So here you can see all the process to understand how it works. So when you induce the cross-linking, you'll have to mix the riboflavin, it's a B2 vitamin, with dextran. The dextran is good because it's gonna maintain the osmolarity of the cornea to avoid the edema. Then you have the photoactivation of the vitamin with the radiation UV. It's performed with a laser machine. I'm going to show you. And it begins the collagen reticulation with the production of free oxygen radicals. So the links formation are stable, intra and intercellular, and you'll have a very hard cornea, and you're going to avoid the progression of the conus. So how you can make the riboflavin to go inside the corneal stroma? You have different techniques. Epi-off, when you take out the epithelium and you steal the riboflavin, that's the traditional way, and that's the way we choose to do it. Epi-on, it's another technique. And iontophoresis, it's the same. It can be on or off, but the time is less. So which are the properties of the riboflavin? Absorption and concentration of the UV radiation. It's also photoactivator in the corneal stroma, and it protects the endothelium. So as I was telling you before, we need to make a combination of dextran with riboflavin because the dextran is going to maintain the osmolarity of the cornea. You can see here the values, the normal value of the osmolarity, and what you can do with the dextran. If you have a very thin cornea, you can use this without dextran. Osmolarity is gonna increase, and the corneal pachymetry is gonna increase also. Remember that you need to have 400 microns at least to do the irradiation. Otherwise, you'll have problems like corneal edema, and you'll damage the endothelial cells. So that's why we need to describe the different kind of irradiation. So as more power you have, less time you need. Be careful with the power, but the good thing is that this reciprocity law described by Bunsen with the technology and the machine is going to help us to save some time. For accelerated cross-linking, we have this 9 millivolts in 10 minutes or 18 millivolts in 5 minutes. So pre-operative, this was one of the questions that someone was writing. You need to consider, as every patient in ophthalmology that you're gonna make or perform a surgery, the undercorrected visual acuity. The pinhole is very important, because if you're gonna propose a surgery to a patient, you need to understand how good is the potential of the retina. If you don't perform the pinhole, you're never gonna know about it. The corrected visual acuity, the refraction, the keratometric values, the pachymetry, the topography, and the endothelial cells. Of course, a fundoscopy is necessary always. What about the Dresden protocol I was telling you before? They proposed this because, well, in 2003, we only had this 30 minutes machine. But the idea is to take out the epithelium. As you can see here in the graphic, the epithelium they used to remove was in the center, just in the ectatic area. And there are some different proposals right now doing cross-linking in the ectatic area. We propose to do a big cross-linking in the complete cornea, because our experience shows us that the evolution can appear in different places of the cornea. So we use, as I was telling you before, the accelerated cross-linking. I'm going to show you a video after we are doing the removal of the epithelium. This should be always performed in the surgery room and under a sterile situation. So after you take out the epithelium, you'll have 20 minutes doing the riboflavin installation. You'll have to do the pachymetry after you remove the epithelium, and you need to be sure that you have 400 microns. Otherwise, as I was telling you before, you can damage the cornea. So we use this machine. It's pretty good and safe, because you can use the 3 different alternatives of time. The crosslink is going to act in the 300 anterior microns. So that's very important, because you need to look for this line that it's called demarcation line. It's like the signature that the crosslinking was performed. But be careful, because if you perform 9 minutes, you're going to see the demarcation line. For example, if you have a patient that has been cross-linked by some other doctor, you can look in the anterior stroma, and this line should be there. But if you do a 5 minutes, maybe you don't find it. We described this difference between 5 and 10 minutes in some congresses in the past. Some complications you have to consider. It's a surgery with a high level of security if you follow all the protocols. In the immediate post-operative, you need to be careful with the epithelial ulcer, the corneal edema, the infections, and the corneal melting. Someone was asking this about the corneal melting and the combination of cross-linking with mitomycin. We don't use it. We only use riboflavin. And the late post-operative complication that has been described is the corneal haze. Again, if you treat correctly the patient with the good protocols, you're not going to have this complication for sure. What is the correct treatment? Use steroids for the first months. Don't take it out after 7 days, because the haze is going to appear. Remember that the crosslink is going to be working from the first month, and then you'll have, like, for more than 1 year, it's going to still be having changes in the patient. So be careful and don't take out the steroids after 1 month. And then you need to control the patient on the 3rd month, because after 3 months, they usually can have this corneal height complication. Contraindication of the cross-linking: pachymetry less than 400 microns, severe dry eye because you will have problems with the epithelialization, Lehman cells deficiency for the same reason, and low endothelial cell account because you might have some damage and you can have like corneal edema. So let's continue with the conclusion. It's a conservative surgical treatment in keratoconus. It has shown safety and effectiveness in multiple reports, and it's indicated in the time to halt the corneal thinning, reducing more complex procedures in the future and preventing the corneal graft. So just a quick question for you all. So the corneal cross-linking can be used for, and you have 5 options. I don't know if you are able to answer this. So it had the progression of the keratoconus. It increased the tolerance to use of contact lens. It improved the corneal surface, improves the refraction of the patient. All the answers are correct. So let's see which one you choose. Okay, no, not all the answers are not correct. Why? This is the correct answer, the first one, halt the progression of the keratoconus, please. Now we're gonna give the second step, where I'm gonna show you the effects of the intracorneal ring and the combined surgery, and you'll understand why it's not gonna change or improve the refraction, and it's not gonna increase the tolerance to the use of contact lens. So, intracorneal rings. The difference between this and the cross-linking is that the cross-link is gonna halt the progression and the intracorneal ring is gonna improve the corneal surface. So the intracorneal ring were first described by Barraquer in 1949 with the thickness law. They were using the rings to reduce high myopia. Again, the corneal map. It's very interesting and it's very important for you to understand the topography and to recognize the parameter and the topography morphology to understand where and which kind of ring you need to use. So how we can choose the patient, the inclusion criteria, which parameters to consider, what kind of or types of rings we have, and the surgery tips you can have. I'm going to show you all of this. So inclusion criteria. So for patients with keratometrics values less than 57 and good pachymetry values, we can choose the intracorneal rings. Of course, we need to be sure that the patient has no scars or leukomas in the center, because otherwise, no matter that we have a regular corneal surface, if we don't have transparency in the cornea, the results are not going to be good. So what to consider before the surgery? Again, the visual acuity, the manifest refraction, the values of the autorefractometer, the corneal topography is necessary to do the calculation, the keratometric values, and the barometric values, sphericity. There are some doctors that use the sphericity to make the calculations and some are don't, but right now it's been really helpful. And then the corneal pachymetry, as I was telling you before. So the surgical plans are usually proposed considering all or some of these parameters, giving like the doctor can give more or less relevance depending on the case to the keratometric values, to the correct visual acuity, or to the pachymetry. Here you have a timeline, as I was telling you before. The Dr. Barraquer described it first in 1949, and until like 2000, we have been changing different theories and incorporating like different technologies. And the last thing you need to know is that right now the treatment of keratoconus is trying to be as more customized as you can. I'm going to show you this classification. It's been described during these few months. We have two different kind of rings. This material is PMMA, and then we have these KERS. It's allogenic intracorneal ring segments made by corneal stroma. It's been described by Dr. Susan Jacobs, and she gave us this picture to show you. And this is a patient with an asymmetrical base intracorneal ring we perform here at the Institute. So you can see the different rings and the different materials. So what about the PMMA? I'm going to show you about Ferrara rings model that it's a flat profile segment, and its compression of the integral edge of the cornea determines the effect. Originally was designed by Paulo Ferrara from Brazil, and then it's been marketed by Kerr Ring, Corneal Ring, AJL, Intrasec, and different brands. Hopefully, I think like they are worldwide. I like always to share the faces of the doctors that have been working on different developments, because I think it's easier to remember. I'm going to show you this is the symmetrical base intracorneal ring. You can see the difference between the asymmetrical base intracorneal ring and the asymmetrical height intracorneal ring. So this is what I was telling you before about how to customize the case. Once you identify the topography, you'll be able to choose the ring and customize. Some important details: as less diameters you have, more effect, and as more thickness you have, more effect. So here you can see how deep we can go with the intracorneal ring. We usually propose 8% of the pachymetry of the patient to put the intracorneal, so you'll avoid the extrusion. It's one of the complications. And you can see here, it's a patient with a previous corneal graft. So how to choose what to do, one or two rings, in which positions? We have a lot of nomograms around that are gonna help us as a guide, but the own experience is the only guide we need to follow. It's very important to understand that the nomograms can tell us what to do or how to put the ring, if to put one or two, but the personal experience is gonna be the best nomogram. So what about the surgical technique? I'm gonna show you this combination procedure. We do the combination between corneal cross-linking and intracorneal ring in the same surgical procedure. If you have femtosecond laser, it's great because it's easier, but you can also use a manual technique, and the results are the same. So you can see here the description of the topography before the surgery, where you can see the correct visual acuity, the refraction, the axis, the incision, the deepness, and the selection of the intracorneal ring. This is the surgery using the femtosecond laser. Here you can see the parameters that we have been choosing for the internal tunnel and the external tunnel. And after a few seconds, and you have, once you have choose the intracorneal ring, you will introduce it through the only incision you have done before, and you need to go deep and then turn the ring through the tunnel until you have the ring in the correct position to correct the corneal ectasia. So you can see here that it's already changing the shape. What to expect from the intracorneal rings? We need to know that they are going to improve the corneal surface. Probably they will improve the visual acuity, correct it, or under-correct it. We're going to reduce the astigmatism, and we are going to reduce the optic aberration. something important for me to share with you is that it's not a refractive surgery. So we're trying to improve the corneal surface. After we have a regular cornea, we can make the arrangements for the refractive surgery. So it's very important to understand the corneal topography, to understand the patterns, to know that the nomograms are a guide and the cases are customized. I'm going to show you this case with this visual acuity in the preoperative. This is the topography and the refraction. And this is the 24 hours. We use one ring, asymmetrical base, so you can see the picture. In the postoperative, you need to take care that the incision is close and the deepness of the ring is as you said before. And here you have the results with a really clear reduction of the astigmatism and a regularization of the cornea. Here there's another case, and I'm just showing you the topography with a like really clear reduction. In this case, we use only one regular base ring. In this case, it's really nice to show you because this case, it's a patient that during the pandemic quarantine couldn't came to our visit, our consultation. So we did the telemedicine consultation, and we asked him to take a picture of the eye. And as you can see, the ring is perfectly in position and the cornea is clear. So it's a really nice surgery also to control by telemedicine in this like pandemic situation. And there's another patient with the same surgery in a different position. And just to show you how we ask the patient to take the picture with no flash, with 10 or 15 centimeters from the eye, they can take the picture. So again, the intracorneal ring is going to regularize the cornea, and the corneal cross-linking is going to improve the biomechanical properties. They are complementary, they are synergic techniques, not competitive. So this is a presentation we did in Lisbon, and then in Cornea Journal, you can see it also, where we can show the efficiency and the safety of doing the bilateral procedure in combination. And this is a patient when we perform cross-linking in one eye and the combined surgery in the other. So it's very important as a conclusion to identify the keratoconic type and the classification. It's mandatory before doing the surgery. The topographic image is required to identify the pattern for achieving the correct selection of intracorneal rings, as well as the number and position of intracorneal rings for each ectatic cornea. And the implantation of asymmetrical base or high, it's an option to customize the treatment. So it's always useful? No. And you can see here a picture of an OCT that this is from a patient that came from hospitals, and they perform cross-linking and intracorneal rings with this ectatic cornea. So of course, it's not going to help the patient to improve the vision. Sometimes we propose the rings in patients thinking that it's going to make it better to improve the contact lens, but it's not always useful. So be careful before doing these decisions. What to do in this kind of patients? The corneal graft. So another question for you all. Oh, whoa, I'm sorry. I don't know what happened there. Again. So, inclusion criterion proposed for intracorneal ring implantation. K values over 57. Pachymetry more than 400 microns. Absence of corneal opacities. Presence of strong striae. No, if we have both striae, we're not going to be able to do the intracorneal ring implantation. We'll have to do a corneal graft. You need to know that it's very important to have less than 57 keratometric values. So finally, let's talk about the corneal graft. The DALK is the gold standard for keratoconus treatment with corneal graft. It's a deep anterior lamellar keratoplasty. The peeling off was described by Dr. Malbran in 1964. And this is a typical cornea for corneal graft selection with keratometric values over 57. You can see a 61 here. It's good pachymetry, but the keratometric values are very high. Be careful, because sometimes here you have some values, but you need to take care of this one. And if you see here, there's a corneal scar also. So if you use corneal rings, it's not going to be useful. Here's a picture of a 24-hour corneal DALK performed by Dr. Lotfi and Dr. Grandin. It's beautiful, and you can see there's no inflammation. It's a safe technique. And here you have the results after 1 year and after the stitches removal, almost with no change in or no astigmatism in the residual refraction. So which are the benefits of the DALK? You avoid the immune rejection of the corneal endothelium. The procedure of extraocular and not in it's extraocular and not intraocular. The topical corticosteroids can usually be discontinued before than the PK, and there's minor loss of endothelial cell loss. And comparing the PK with the DALK, you may have superior resistance to rupture of the globe after trauma. And the sutures can be removed early with a DALK. Always try to do this. So at the beginning it can be more difficult, but once you learn the technique, it's easier. What to do after you have performed the corneal graft? It's not over. So it seems to be over, but no. We need to consider this corneal cross-linking in the peripheral area after the corneal graft also. So as I was showing you before this picture, we have a trepanation area in the center. This is a patient of 29-year-old with the diagnosis of keratoconus, and the DALK was performed in 2011. This was the final refraction. It was very good and very low astigmatism. So the patient left and came to the consultation again, and we have evidence of histopathological variation in keratoconus after the graft, and we know that you can have a recurrence of the keratoconus in the corneal graft, but mostly in the union between the donor and the receptor. So Dr. Malbran, again, he described the corneal ectasia in the peripheral ring, and he also described a surgical technique to make a reconstruction of the cornea. So the idea to show you is that we need to halt the progression after you have performed the corneal graft, because it's really important to avoid the progression again for these patients. You can see here a case. That case I was showing you before. Well, he came after 6 years with this corneal ectasia. The corneal ectasia was because a thinning in the peripheral ring in the superior area. So what we propose for these cases is to do intracorneal rings to reduce the astigmatism, but the most important thing is to do the cross-linking with epithelial debridation in the peripheral ring and with the same technique. I'm going to show you a short video of a patient with a corneal graft that we have. We performed this surgery doing the tunnel and the implantation of the intracorneal rings. And after we did the installation of the riboflavin, we did the irradiation as you can see there. We were covering the center of the graft because we don't want to irradiate a healthy cornea. Here is the postoperative picture. You can see the ring, the scar of the graft, and the transparency of the cornea. It's very safe. What's going to happen if this patient has some refractive error after this? We can propose different techniques to resolve the refractive errors. So if the patient don't want to use contact lens or glasses, you can use phakic ICL. I'm going to show you this case of a patient with a high myopia in both eyes. In the right eye, we did DALK. In the left eye, we did a combined procedure of cross-linking and intracorneal rings. Here are the topographies after the graft. You can see here, this was the refraction. And after the intracorneal rings, the topography was much better. Here's the refraction. So Dr. Zaldivar performed a surgery with a phakic ICL. And you can see here the image of the phakic ICL in the intracorneal rings eye and in the DALK. And these are the results after 1.5 years of the surgery. And this is the final refraction. So this patient is a pilot. You can see you can have excellent results. So as a conclusion, IOL are good options to treat residual refractive errors in keratoconic patients. And before the ICL implantation, you need to be sure to regularize the cornea surface and to halt the progression of the ectasia. Well, it's been long, but we're going finishing this presentation. As a final conclusion, the early diagnosis and adequate treatment of the keratoconus allows us to halt the evolution and to have a prompt visual rehabilitation of the patient. Promotion and prevention are important tools for our patients. Remember that most of them are young patients with an active life, and we need to help them to go back to their regular life. Thank you very much to my mentors, Dr. Grandin and Dr. Lotfi, and well, just a picture to finish of Mendoza, the city where I live. So we have a few minutes left for some questions. Well, my opinion in epoosmolar, I already did that. Epoosmolar cross-linking. We try not to do that, but we can use it to make a safe cross-linking. Idiopathic endothelitis. We don't have any idiopathic endothelitis after cross-linking. We don't have that evidence. What happens if the keratoconus is not treated? The keratoconus, if you don't treat it, you're gonna have evolution probably. If you have progression, if you don't treat it, you'll have evolution and you will need to do corneal graft. The good thing to tell the patients with keratoconus that I always tell them is not to be afraid, because if they have a safe and healthy retina, they're never gonna get blind. The patients are always like afraid of that. And sometimes I tell the patient that imagine that they are fixing like a car. If you have a good motor, you can only change the glasses of the car and everything's going to work like properly. So if they have a good retina and you fix the cornea, they're going to be able to see. Some more questions I have been answering, I guess, most of them. Oh, the intracorneal rings are not changing the endothelial pump mechanism, not at all, because it's only in the stroma. It's not changing at all. Yeah, combined surgery for cross-linking and intracorneal rings reduce the rehabilitation time for young patients. About which one has more success, all the surgeries are good, but the important thing is to know that as early you do the surgery, the best refractive results you will have. For IOL calculation after corneal graft, you do the same as a typical calculation. My opinion for scleral contact lens. So it's good for rehabilitation, but it's transitory. I mean, if you can't do, for example, right now with the pandemic situation, we are not able to perform corneal graft, so the scleral lens are good. But you need to tell the patient that it's going to be changing. Like usually we propose cross-linking and scleral lens until they do or perform the corneal graft. Remember that in the future that patient is going to have a cataract. And if you do the cataract surgery, you need to have a regular cornea. Well, again, about the cross-linking and the intracorneal ring, which one is earlier? We perform them together at the same moment, usually. You can do it all together. You don't need to wait. There are many questions about the same. IOL toric, yes. We do toric implantation. Dr. Zaldivar performed the surgery. The cross-linking usually is not gonna improve the vision. It's gonna make like just small changes in the topography and in the final refraction. Okay, we don't have experience with this contact lens cross-linking. My friend Dr. Susan Jacobs performed that a lot for corneas below 400 microns. We don't. Why not using a full ring? Because usually the full rings are for very big ectasia, corneal ectasia, and usually the visual acuity is not going to be that well corrected. So if you recognize the topography and the corneal pattern, you'll be able to correct with one ring or maybe two, but not with a big one. It was busy in the clinic. Oh, okay. Yeah, the demarcation line is a good indicator for effective cross-linking. Yes, it means that the cross-link it's there. It's like a scar, you know. But if you don't have the demarcation line, maybe you did a 5 minutes surgery. So don't worry about that. I'm sorry, yeah. Why is the DALK inevitable if cross-linking can give us corneal stability in terms of progression? No. Like what I was telling before is that if you do a cross-linking, probably you're not going to have to make a DALK. But after a DALK, you need to be careful with the progression and to try to perform the cross-linking if you see progression in the peripheral ring. How often we repeat the cross-linking? Never. we have never had the necessity in any patient to repeat it. How can keratoconus be diagnosed early without a topography? So this is a very good question. I did a protocol that I didn't share it today for those doctors or clinics that don't have topography. So with a good semiology, you'll be able to diagnose the keratoconus with keratometrics values over 46. You need to suspect with corrected visual acuity that is not good at all. When you have different axes between the autorefractometer and the visual acuity, and if you have, of course, some of the biomicroscopical signs, like the nerves, the scars. What is the target area in cross-linking after DALK? We do in all the peripheral cornea, complete. If you receive a patient with cross-linking already done, and you just the case indicated for an intracorneal ring, you can do it immediately or you wait for some time. Usually we can make it immediately. We don't wait. Can one perform a cross-linking on an adult of 40 plus? Of course. We have been doing cross-linking until like 60, 70, 80 years old. It's a really important concept that the age it's not related with the progression. Corneal transplantation and corneal graft, it's the same. I'm sorry that if there was a confusion with that, it's the same. Different terminology, but it's the same. It's a very good question of Dr. Manda. If it's a must to cross-link all patients after DALK, it is also for PK. It's not a must, but you need to consider. Like usually we know with the evolution of our follow-up patients that the patients with DALK or PK indication with very thin corneas in the preoperative probably you will have evolution. So you tell the patient about this before the graft, and they don't want to go back there. So if you have a good follow-up, you will be able to know if it's necessary or not for both DALK or PK. Yes. Can you combine cross-linking and ICL implantation or ICL implantation with intracorneal rings? Okay. I think this question was already answered during the presentation. Yes, you can do ICL after cross-linking. We wait 1 year. And you can do also after intracorneal rings after 1 year because you need to have a stabilized cornea. If it's possible to repeat cross-linking, if it keep progressing, yes. You can do it, but we don't have this experience because we never had a progression. What to do if a DALK fails? Well, depending on the cause, but usually you don't have rejection on anterior lamellar keratoplasty. Results between cross-linking and cross-linking with intracorneal rings are comparable or one is superior. They are not competitive. As I was telling you before, they are complementary. Okay, I think we are done with the time. There are a lot of questions. I'll be saving this question if you want me to answer them after I finish the webinar. I'll be in contact with everyone. We have my contact here. Thank you everyone for sharing this hour of keratoconus. I think it's going to be useful. Please feel free to make any questions or contact me. If I can help you, I'll be happy to do that.